Engrossing as ever, Dr. Sindhil, and may I call upon the next speaker of Dr. Chetan Deshmukh, and Dr. Chetan would be talking on CNS disease in HER2 positive metastatic breast cancer.
Good morning, ladies and gentlemen. Thank you, Nikhil and Vamshi, for inviting me here. I may be one of the unique people in the hall that I've attended both the first and the 50th ICON conference. So thank you, Dr. Parikh sir, for this unique privilege. I'm going to speak about a rather disappointing or a depressing scenario, CNS metastasis in HER2 positive disease. HER2 has a predilection for developing CNS mets. Patients with metastatic disease have almost a 50% chance of developing CNS disease during the course of their illness. No matter how much our anti-HER2 therapy you escalate in the adjuvant setting, you add lapatinib, you add TDM1, as has been seen in the ALTO or the Catherine study, it does not reduce the risk of having CNS disease. The three typical scenarios are CNS disease with systemic disease, isolated CNS progression, which is the toughest because there is hardly any data for it, and leptomeningeal disease, which is again a very, very unrewarding situation. We use surgery, radiation therapy, systemic therapy as alternatives or in sequence. If it's a single large lesion with pressure effects and the systemic disease is well controlled or absent, then of course surgery is the preferred modality. And if there are multiple lesions or single small inaccessible lesions, then they are best treated with radiation therapy. The drugs which we use do not have any genetic tests or any of those fancy molecular markers which we see, because very often patients with CNS disease are excluded from these studies and none of the drugs cross the blood-brain barrier. We have, thank you. So we have lapatinib plus capecitabine, neratinib, TDM1, and now we have trastuzumab deruxtecan, and tucatinib is yet to come. Lapatinib was one of the first drugs to be found useful in CNS disease because it has CNS penetration, and hence LapCape was one of the favorite combinations. Many phase 2 studies, not a great data, but these 12 studies were put together, close to 800 patients, and the pooled overall response rate was 21.4%. Some of these patients had received only lapatinib. So if you combine patients who have received lapatinib and capecitabine, the ORR reached to almost 30%. And the pooled median PFS and OS were 4.1 and 11.2 months respectively. So not something very great, but this combination is easily accessible, reasonably well tolerated, affordable, and that is why it remains a preferred modality of treatment even today. This study probably came as a desperation that nothing is working, so why not use something which has worked in the systemic setting? You give trastuzumab in a higher dose, 6 mg per kilogram every week. So 18 mg per kg every 3 weekly. That was a very big dose. They did find some responses, but I don't think anybody has reproduced this study. Then came TDM1, and this is the retrospective exploratory analysis of the Emilia study, where TDM1 was pitted against lapatinib. Of the 991 patients, almost 10%, 95 patients had CNS metastasis at baseline, and CNS progression did not differ significantly in the TDM1 versus lapatinib arm, but the PFS was more or less similar, 5.5 months versus 7.2 months for TDM1, but the overall survival was much better with TDM1. Probably TDM1 has a better systemic effect, and that reflected in the better overall survival. Now coming down to the latest kid on the block, trastuzumab deruxtecan in CNS disease. So most of these studies have had small patients of patients who had brain metastasis. This was a subgroup analysis of patients with brain metastasis in the Destiny study, Destiny 03 study, 82 patients who received trastuzumab deruxtecan and TDM1, the comparison between the two. And the treatment with TDXT significantly improved everything. PFS, ORR, intracranial response was better in brain metastasis. And the 12-month PFS in this subgroup was 72% with TDXT and 20.9% with TDM1. It is very important, it's an important consideration. The overall response rate, 67.4 versus 20.5, that is improvement. For a metastatic disease, improving a better overall response rate improves symptoms, improves quality of life. The median duration of response again was much better with TDXT. For intracranial responses, 27.8% of patients treated with TDXT had a complete intracranial response, which is something which is unheard till today, compared to only 2.8%. So, phenomenal response even inside the brain. That is what made this. That is what probably makes this drug everybody's favorite. There were a few other phase 2 studies also. Another small study. This is a very, very small study, just 15 patients, but the waterfall plot is really interesting. Out of the 15 patients, 2 patients had a complete intracranial response, 9 patients had partial, and 3 patients had stable disease without any new safety signals, without deterioration in the global quality of life or cognitive functioning. So definitely looks to be an impressive drug. Emboldened by this success, they then moved to a more aggressive subset. DEBRA study had all comers. It had HER2 low as well as HER2 positive population. But that cohort 3 and cohort 5, these were patients who had brain mets and were progressing on previous therapy. They had received whole brain radiation therapy. So this is obviously a little more unfavorable population. Plus you had patients who had leptomeningeal disease, a subset which is rather difficult to treat. Even in this group, the responses, intracranial responses, especially in the HER2 positive subset, were quite encouraging. So this study was presented at the San Antonio a few months ago. This is an injectable therapy, costly therapy. It has its own share of systemic toxicity as well. So why not something oral? That has always been the favorite of most patients. And this was the HER2 CLIMB study published in 2020 NEJM. Tucatinib plus trastuzumab capecitabine, the two arms being tucatinib trastuzumab versus placebo trastuzumab and capecitabine. The reason why this study is important is the number of patients with brain metastasis, close to 300 patients. That is a big number for any study. Most of these studies don't have that kind of number. Of these 291 patients, 174 patients had active brain metastasis, of which 108 had been pre-treated and were yet progressing, and 66 patients were untreated. So a big chunk of patients who had fairly active brain metastasis, and almost all of these patients, 97 and 96.8% patients had extracranial systemic disease as well. So these patients had synchronous metastatic disease at both places. Almost 70% of patients in both groups had received prior radiation therapy. So these patients were treated, they had symptomatic brain mets, and the benefit of tucatinib was seen across all subsets. There was CNS PFS benefits in patients with brain mets, there was OS benefit in patients with brain mets. Even when you split the group of CNS mets, there was CNS PFS benefit in patients with active brain mets, OS benefit with active brain mets, and it was also the same survival benefit was seen in patients who had stable brain metastasis. The intracranial response rate was also significantly better with the tucatinib arm, and the duration of intracranial response was also almost double in the tucatinib plus trastuzumab arm. The side effect profile, not very troublesome, more or less similar. Remember, the control arm also had capecitabine. So capecitabine is a little difficult drug, and that probably increased the side effect profile, and that is why you see both of these side effects being seen at par. Emboldened by this study, they now decided to do away with the capecitabine. The HER2 CLIMB-2 study, again published at San Antonio a few months ago. TDM1 plus tucatinib versus TDM1 placebo. The TDM1 was the better drug, as shown earlier in the Emilia study, that it had both systemic as well as intracranial response rate. And again, the early results appear very encouraging. The PFS is better with TDM1 tucatinib arm versus TDM1 plus placebo, and the same PFS benefit is also maintained in patients with brain metastasis, 7.81 months versus 5.7 months. The side effect profile, well, looks more or less similar in the HER2 CLIMB original study also. Most of the treatment emergent adverse events were similar in both the arms. The discontinuation arm is discontinuation rate was slightly more in the tucatinib arm, and we all know that diarrhea and transaminitis is going to be a challenge with this drug. Another interesting study, again, just from our own Tata Memorial Hospital, that intrathecal trastuzumab. This is something which all of us have been itching to try, but TMH people actually went ahead and did it. that patients who had leptomeningeal disease, they received intrathecal trastuzumab, and both these patients had a good symptomatic improvement as well as the survival was also better. So CNS disease and HER2 positive disease, we all know that now the systemic therapy is so effective that systemic disease remains well controlled and CNS remains a challenge, being probably a sanctuary site. Currently available therapies only have modest benefit with significant toxicity. Probably availability of tucatinib and deruxtecan may improve outcome and survival in this subset of patients. So I hope to see some light at the end of the tunnel. Thank you.
Thank you, Dr. Chetan.